We will now continue with Chapter 40, Part 6, Pulmonary Dysfunction. Okay, let's talk a little bit about cystic fibrosis. It is a chronic lung disease. It occurs 1 in 3,000 live births of Caucasian infants, 1 in 17,000 births in African American infants. Prevalence is most prevalent in people of Northern and Central European descent. Genetically, it's an inherited recessive trait, so both parents have to carry the gene for the child to get it, with an overall incidence of 1 in 4 if both parents carry the gene. Part of the mandatory state newborn screening, it's commonly referred to as the PKU test, allows for early detection and treatment. Basic defect is an exocrine gland dysfunction that includes increased thickness of mucous membrane secretions and is a loss of electrolytes in the sweat due to abnormal chloride movements. Multi-system disease effects such as respiratory system. There's thick secretions that obstruct small and large airways, which equals dyspnea. The digestive system, there's thick secretions prevent the digestive enzymes from flowing, which equals poor absorption of food and nutrients, results in growth failure. We'll see bulky, frothy, foul-smelling stools as a result of undigested fat. Skin, they can have loss of electrolytes such as sodium and chloride in the sweat, causes a salty skin surface, predisposes the child to electrolyte imbalances during hot weather. And in the reproductive system, the thick secretions decrease sperm motility and thick cervical mucus, which can keep sperm from reaching the fallopian tubes. For lungs, the involvement includes air passages become clogged with mucus, bronchioles or widespread obstruction due to mucus. Symptoms include dyspnea, expiration is difficult, cyanosis, wheezing, atelectasis can occur. The shape of the chest is usually barrel-shaped, increased diameter across the front and back. For the heart, the right ventricle may become enlarged because it's working harder to supply the lungs with blood due to the obstructed passages from the mucus. Fingers can have clubbing due to chronic lack of oxygen. Incidence of infections like easily get staph, H. influenza, E. coli, and Pseudomonas infections. Prevention of respiratory infections is crucial. You want to isolate CF patients from those with respiratory infections or carriers of organisms. Hospital stays only if necessary and are usually short to help prevent nosocomial infection or cross-contamination infections. Gradual progression of the disease follows chronic infection. They'll have bronchial epithelium that is destroyed. Infection spreads to peribronchial tissues, weakening bronchial walls. Peribronchial fibrosis ensues, and oxygen and carbon dioxide exchange decreases. So the pancreas involvement changes occur due to the thick secretions blocking the flow of pancreatic enzymes. For digestion, food, especially fats and protein, are not properly digested and used by the body, which results in fatty, foul-smelling feces, usually light in color. There's presence of meconium ileus at birth, which indicates CF. Thick meconium obstructs the intestine in the fetus in utero, resulting in a meconium ileus caused by lack of pancreatic enzymes that normally digest proteins in the meconium. Symptoms include absence of stools, abdominal distension, and vomiting within hours after birth. With the sweat glands, the sweat, tears, and saliva become abnormally salty. They could do a sweat test to confirm the diagnosis of CF up to age 20. 60 milliequivalents of sodium indicates CF greater if it is the best diagnostic tool for the CF. Prognosis, its estimated life expectancy for a child born with CF in 2009 to be about 37.4 years. It's progressive and an incurable disease. Transplantation increases life expectancy. So when we talk about complications, there's rectal prolapse, there's liver, hard, nodular, and enlarged, uh, cor pulmonale, which is a heart strain caused by poor lung function, often is the cause of death in children with CF. There's a vitamin A deficiency. There's sexual development that can be delayed. Males generally become sterile, but sexual function is not impaired. Females may experience secondary amenorrhea, which is an absence of period, during the exacerbations. So for respiratory management, we use airway clearance therapies such as CPT, pursed-lipped breathing. Then there's aerosol bronchodilator medication, and it's administered before CPT and postural drainage. It's administered when the child is wheezing for signs of reactive airway disease. There's physical exercise, which stimulates mucus excretion and provides sense of well-being. We have aggressive treatment of pulmonary infections. These are characteristic signs of pulmonary infections in CF kids, which includes fever, tachypnea, and chest pains. There's aerosolized antibiotics that can be prescribed for frequent pulmonary exacerbations. There's home intravenous antibiotic therapy. It's offered as an alternative to hospitalization. They'll need PICC lines or portacath access, preferred for the long-term administration. So for pursed lip breathing, it's a forced expiration with the glottis partially closed, which helps to move the secretions from the small airways so that the subsequent coughing can move secretions forcefully from the large airways. Okay, so for postural drainage and chest physiotherapy or chest clapping, this is CPT and postural drainage that are typically performed twice daily. It's performed more frequently if needed, such as in cases of infections. So for GI management, we're going to have replacement of pancreatic enzymes. We're going to provide a high protein, high calorie diet, as much as 150% recommended dietary allowance. No salt restriction. Allow the children to eat salt freely. Pancreatic enzyme powder given with applesauce or other non-starch, non-fat, non-protein food. And think about why we would do that. And then the relief of intestinal obstructions, such as an ileus, with the administration of Go Lightly or other laxatives. So reduction of rectal prolapse with a gloved lubricated finger. Further treatment involves attempting to decrease the bulk of daily stools with the enzyme replacement. May have treatment of chronic gastrointestinal reflux with histamine receptor agonist and GI motility drug, in addition to dietary modifications and upright positioning after meals. Diet and nutrition for oral pancreatic enzymes are given with each meal and snack to replace the enzymes the body can't produce. And you want to hold it if the child's not eating or they are NPO. They may get supplements such as vitamin A, D, E, K, iron, and zinc. You want to make sure you're doing daily weights and I's and O's recorded. Hygiene. If they have diapers, make sure the diaper area is cleansed after each bowel movement or urination. Skin, you want to apply protective ointment to the skin in the diaper area. For oral hygiene, give good oral hygiene. It is very necessary. And then you want to provide the oral care, especially after postural drainage, if possible. For education and support, in long-term care, the goal is minimizing complications, ensuring adequate hygiene, promoting growth and development. For continued education and support, the diet, you want to give parents specific instructions regarding their diet, medication, postural drainage, prevention of infection, rest, and importance of medical supervision. Genetically advised genetic counseling. For child, provide children with simple, straightforward answers about CF they need to know, why they have to take this medicine with every meal, using the nebulizer, postural drainage, and how to handle the equipment. Separation. Encourage rooming in during hospitalization if possible to prevent separation anxiety, and encourage parents to stay with the child as much as possible. For OSAS, diagnosis is made in sleep study. It affects about 2% of all children. Most do not have daytime sleepiness. Signs and symptoms are habitual snoring, interrupted or disturbed sleep patterns, enuresis, and daytime neural behavioral problems. Treatment and management is adenotonsillectomy may improve the condition. CPAP may be helpful in older children whose condition persists after surgical intervention. And at last, respiratory failure. Clinical manifestations, you want to look at box 40-17 on page 1242 of your textbook. Diagnostic evaluation. Diagnosis is based on the combination of three sources of information. Also look at page 1242 of your textbook. Therapeutic management. Goals are to maintain ventilation and maximize oxygen delivery, correct hypoxemia, correct the underlying cause, and prevent MODS, multiple organ dysfunction syndrome. This concludes part 6 of chapter 40.